JP. Dr. JP, if you're with us, you should be able to share your screen and take us through the contents of Pillar 1 in the new National Cancer Control Strategy Plan 2023 to 2027.
All right. Thank you, Dr. Mwenda. Thank you, colleagues. I want to thank all of you who have joined the webinar today. Today we are talking matters cancer and disseminating the cancer control strategy. Kindly allow me to keep my video off. I fear that my network may not support may not be very stable if I put my video on. So kindly bear with me. I hope you can now see my screen. I'm going to take us through the proposed strategy touching on cancer pillar 1. Thank you for the thumbs up. And pillar 1 is basically on cancer prevention and early detection. I'm going to take us through a brief background and context, then the overarching goal, and then really the heart of the matter, which is the strategy, which has a total of 5 strategic objectives, several strategies under each strategic objective, and several activities to support each strategy. So flow with me. This is a picture showing how our own strategy, our previous strategy was like this. Actually, I should probably have added another one for the first strategy. So this was the second strategy where my pointer is. And this is the current strategy that we are discussing today. I believe shortly you'll be able to download it on the MOH website. So in terms of prevention and early detection, in Kenya, the top cancers actually are amenable to population level screening and have been outlined in our cancer screening guidelines as cancers that we should target to screen at population level, meaning that we identify a target population and we screen them at a certain point in time, and we actually establish a program complete with monitoring and evaluation. So these 4 cancers, cervical, breast, colorectal, and prostate cancers, account for 43% of all new cancer diagnoses in Kenya and almost 37% of deaths. We are relying on data from GlobalCan 2020. And another fact is that 5 to 10% of all cancers globally are attributed to genetic factors. Genetic factors, as you know, are not modifiable, but they are amenable to early diagnosis and treatment. So we have included them in this strategy. Looking at lifestyle risk factors, I put these pictures here. Some of them may look a bit comical, but this is, I understand, Homo sapiens, I don't know, another sapiens, but this is the kind of lifestyle that many people are living nowadays. Very sedentary lifestyle where we sit and put a screen in front of us, another screen in our hand or a remote control, and eating, unhealthy things, drinking unhealthy drinks. More specifically, alcohol, which now, previously we were talking about harmful use of alcohol, but it has been shown that there is no use of alcohol that is not harmful. And then tobacco, smoking, unhealthy food. These are the foods that we like. I'm not picking on any brands. And these are the other foods that we like and our children like. So these are some of the lifestyle risks, which I will unpack a bit. Tobacco is the most common, most important cancer risk factor. Tobacco has been shown to have over 70 ingredients that are harmful. And yet people who still, smoke tobacco. Tobacco has been shown to be responsible for 1/5 of all cancers, and actually a third of cancer-related deaths globally are attributed to tobacco. Tobacco use in Kenya, it was estimated in 2015 in an NCD survey called the STEP survey. It was estimated that 13.3% of adults in Kenya use tobacco. The mean age of initiating smoking was found to be around 20 years, and there is also secondhand smoke, of which 30% exposure occurs in the workplace and 24% in the homes. I think the picture may have changed quite a bit, especially since we have the tobacco laws, which have been enforced to a certain extent. I mean, now previously we know we didn't have smoke-free zones, we didn't have designated smoking areas, but now we do, and that is good. Alcohol, we find 19% of adults consume alcohol. How about overweight and obesity? It affects, or rather 1 in 3 Kenyans are found to be obese. Healthy diet. We are supposed to consume 5 servings of fruit and vegetables daily. I wonder about you. Personally, I struggle to consume these 5 servings daily. It's found that 7% of Kenyans only are the ones who are doing that. So you see, we are exposed to these lifestyle risk factors. Infectious diseases associated with cancer. There are quite a number of viral infections that are known cancer risk factors and can be prevented through vaccination. In Kenya, we have routine vaccination programs for hepatitis B and human papillomavirus, HPV. However, our vaccination coverage, we are still low, but we are making progress, but we can do better, especially HPV vaccination, which is prevention for cervical cancer. We are at 58% with the first dose and 29% for the second dose, according to KFIS data for 2022. Whereas for hepatitis B vaccine, which is given in 3 doses, and this is within it used to be called pentavalent vaccine, but I think it has more than 5 disease, 5 illnesses that it targets to prevent, but we are at 86% with that. In terms of screening programs, because when we address lifestyle risk factors and we address infectious diseases, we are trying to look at primary prevention, like the vaccination and avoidance of risk factors. But secondary prevention, now we come under screening programs. In Kenya, we have established population-based screening programs for breast and cervical cancer. Coverage for cervical cancer was estimated at 31%. We need to screen 1.6 million women every year so that we can achieve targets for elimination that have been set by WHO, which include 90% of girls being vaccinated with HPV vaccine by age 15, 70% of women receiving screening using a high precision test. And we have HPV test, which is available, not so widely, but it is available in some parts of our country. And then 90% of all women who are diagnosed to have cervical cancer or pre-cancer being treated. So 90-70-90 goals are what we are working towards. And for us to do that, we need to work together to screen 1.6 million women every year. For our breast cancer screening program, we target 4.8 million women annually. We are looking at clinical breast exams. We are looking at mammography for women above 40 years and ultrasound as well. So that is the breast cancer screening program. For colorectal cancer, we do not yet have a screening program, but we will need to establish one so that we can achieve secondary prevention of cancers. And our screening guidelines recommend screening of all everyone who is above 45 years should start being screened for colorectal cancer, and they can be screened using, first of all, fecal occult blood test. And if it is found to be abnormal, then they are done for colonoscopy. So these are the things that we are working on at the Cancer Control Program. And this is basically now the interventions that we have prioritized in this strategy. What is our overarching goal for Pillar 1? Our overarching goal is to provide quality and equitable cancer prevention and early detection services in order to reduce the preventable burden of cancer. I would underline preventable burden of cancer, because we are having a lot of burden of cancer. Cancers that are preventable are really causing us a lot of, suffering, in terms of emotional, physical, financial, economical. So we are looking at providing quality and equitable services to reduce that burden. And how are we going to do it? Through our strategic objectives. These are the strategic objectives, and I'll highlight the key areas that are addressed by these strategic objectives. The first strategic objective addresses exposure to modifiable risk factors and addressing the underlying social and environmental determinants. 1.2 addresses non-modifiable risk factors. These include age, ethnicity, race, family, history, and gender. Then we have 1.3, which focuses on secondary prevention through screening and early diagnosis, and importantly, linkage to care. It is not helpful to screen without linking to care the positive cases that we find. 1.4 is looking at early detection of childhood cancers. And this is a very important element in our strategy, because we are trying and stable. But I think that's sorted now. Yeah, we are at around 19% accurate, and when we really try in some centers, it's at 30%. But we want to reach a better cure rate for our childhood cancers. And lastly, we have multi-sectoral response and coordination, so that everybody can work together towards these other 4 strategic objectives. So we are going to look at the strategies and look at the activities under each strategy. The first one being dealing with modifiable risk factors and the determinants. So we look at tobacco. The first strategy is on reduction of prevalence of use of tobacco and tobacco-related products and byproducts. We are looking at reducing from 13.3 to 6.5% by 2028, by the end of this strategy. And here, what activities have we outlined in the strategy? We have outlined advocating for increased taxation of tobacco products so that we limit access, and WHO recommends taxation of up to 70% of the retail price. So we are several sub-activities under this in order to achieve that 70%. Secondly, we want to integrate tobacco control key messages in cancer education, awareness, and mass media campaigns, so that people can link cancer, tobacco, and cancer. Then we also want to integrate tobacco control strategies into cancer prevention control activities in the community, in schools, in workplaces. And lastly, we want to support provision of tobacco cessation services. There are those who are trying to stop using tobacco products, and we must support them. And there's even a guideline that has been developed by the Ministry of Health that will help, that is supposed to guide health workers to help people to cease tobacco use. So we are looking at having counseling and pharmacotherapy through integrating these services at our cancer treatment centers and at other health facilities. Now, our second strategy. The first one was dealing with tobacco. The second one is dealing with alcohol. We want to reduce alcohol use prevalence from 19% to 10%. So how are we going to do this? Number one, advocating for and participating in the review of and comprehensive implementation of the Alcoholic Drinks Control Act 2010. This is a famous Mutudo. It needs to be reviewed and aligned with the devolution and other, legal frameworks that are now existing. And also counties are supposed to have their own alcoholic drinks control act. Some counties have, others don't. So all counties are supposed to have their own domesticated alcoholic drinks control act. The second activity is to advocate for increased excise taxation on alcohol and alcoholic products. And the third one is on regulations on restriction of marketing and promotion of alcoholic products. So we are looking at supporting the review and implementation of this regulation. You find that it's very common to find billboards that are advertising alcohol. Of course, there's always a small line that alcohol use is harmful for you to your health, but this needs to be strengthened and implemented well in restricting the marketing and promotion of alcoholic products. The fourth one is on key messages, information, education, and communication materials, whereby we want to integrate these in cancer awareness, our mass media campaign, and public education in schools, in workplaces, and in the community, so that we can make people more aware of the harms or the link between alcohol and cancer. We are on to our third strategy. Our third strategy is on reducing consumption of unhealthy diets, reducing the prevalence of physical inactivity, and also overweight and obesity. Here we are looking at it in the first activity, which is integrating education and awareness interventions to promote healthy nutrition, physical activity, and also to prevent overweight and obesity in cancer control activities at these levels, schools, communities, and health facilities. So really focusing on education and awareness. The second one is focusing on enacting policies and legislation to increase taxation and reduce marketing and advertising of unhealthy foods and drinks. And then also, in addition, providing incentives for access and sale of healthy foods. You find that it is easier to access unhealthy foods than healthy foods. So we need to find a way through policy and legislation so that we can increase taxation, reduce marketing, and provide incentives, so that we can achieve our goal. The third one is on urban and city designs. The policies currently and the design of our cities, even upcoming cities, they don't seem to take into consideration, people having a fit lifestyle. If you try, for example, to walk to work, there are many dangers therein. If you cannot even decide to cycle. But we know that currently there are cities in the world where it is actually preferable for you to cycle or to walk. So that's where we are looking at working with stakeholders so that we can promote active lifestyle through our designs. And lastly, we want to promote establishment of workplace and community wellness programs. These are very important to support this strategy. We are on our fourth strategy, still in our first strategic objective, and this one addresses environmental and occupational risk factors. This is an area where we have lagged behind generally as a country and want to take leaps so that even if we begin with small steps. So the activities here include instituting active surveillance programs for food, environmental, and occupational risk factors for cancer. We are also looking at public awareness and sensitizing communities on these risk factors. The third one is advocating for review, enactment, and enforcement of existing policies, laws, and regulations and guidelines so that we limit exposure to these environmental, occupational, and pollutants. We are looking at that policy, addressing that from a policy level and legal frameworks. Number 4 is on promoting research. Really, there's a lot of myths and misconceptions around this as well. And so research needs to be done so that we can know what is the role of chemicals, pesticides, environmental and occupational risk factors in causing cancer. And we want to be able to segregate this data by region so that maybe we can see if this particular cancer is common in this area, could it be because of this environmental or occupational risk factor? So that's the question that research needs to help us to answer. The 5th strategy under this objective, still addressing the modifiable risk factors, is dealing with the infectious agents associated with cancer, and I mentioned them earlier. So here we want to promote routine HPV vaccination in all eligible girls so that we achieve the 90% HPV vaccination by 2030. We also want to promote healthy sexual behavior. This has been shown to reduce transmission of various viruses, including HPV, hepatitis B and C, HIV, HHV-8, HTLV-1, and EBV, among others. You can read up more about these viruses and their cancer causation, but maybe I can just highlight, for example, HIV. HIV is associated with a number of cancers. For example, cervical cancer is an AIDS-defining illness. I think also primary brain lymphoma is known to be an AIDS-defining illness. So when your immunity is affected, you cannot fight. Your body cannot fight even irregular and uncontrolled multiplication of the cells in the body. The 3rd one, we are looking at developing and implementing targeted screening and treatment program for hepatitis B virus to address liver cancers. We have some counties where it seems to be more prevalent, and so something needs to be done in those counties. Number 4 is on promoting availability and appropriate use of diagnostic therapeutic interventions for these viruses and parasites and so on, including hepatitis B, hepatitis C, schistosomiasis, H. pylori, and HIV. These conditions or these viruses, these organisms cause various diseases that are associated with cancer in one way or another. And so we need to also see how do we improve diagnosis and therapeutic treatment of these conditions. We are now moving to our 2nd strategic objective. Actually, pillar 1 is usually very long, but remember it is the base. It's the base of our program. It's where majority of our energy needs to be. So looking at strategic objective 1.2, we are addressing non-modifiable risk factors. The 1st one is creating awareness among the general public on familial and hereditary cancers. So here it includes the integration of key messages into existing cancer IEC materials, integrating content also on these cancers in community health strategy materials, so that when we train our CHVs, we enlighten them also, so that they can create awareness in the general public. The 2nd strategy here, still on non-modifiable, is on building the capacity of health workers for screening and linkage to diagnosis and care for these cancers that are familial or hereditary. Here we need to integrate the content into training materials for primary health workers. We need to promote training of health workers, and lastly, adopt a screening tool to be used by healthcare workers at primary level to identify individuals who may be at high risk of familial and hereditary cancers. Now we are on strategic objective 1.3, which is on improving secondary prevention of cancer through screening, early diagnosis, and linkage to care. So here the focus is on secondary prevention. And the 1st strategy here is on improving access to quality cancer screening and early diagnosis interventions. And the first activity we are going to do here is review and update our national cancer screening guidelines, which are now 5 years old. So we need to review and see and align with new global frameworks and direction, new evidence, also align with our current situation in our country. So that is our first activity. The second one revolves around provision of organized cancer screening and early diagnosis services at appropriate service delivery points in all health facilities. It includes integration. And the third one is on promoting access to these services for hard-to-reach groups. We have hard-to-reach groups, we have marginalized population, we have different communities with different needs. And so some of what we are looking at is self-care strategies. The fourth one, I think I mentioned this earlier, and now we have this, we mentioned this in the background that we need to do this, and we have outlined it as an activity to establish a national colorectal cancer screening program at population level through a phased approach. And lastly, to promote integrated programs for early identification of lung cancer in our TB clinics and chest clinics. We are now on activity, still on activities. Now for our second strategy under secondary prevention. And here we are looking at our health workforce and healthcare service delivery systems. So the first activity here to improve our health workforce is to utilize training packages that are harmonized for in-service training of healthcare providers, including e-learning platforms. We have some e-learning platforms and we need to utilize this and any other innovative way that we can reach as many health workers as possible. The second one is on increasing the number and diversity of trained health workers to deliver these services as per the guidelines. The third one is to include screening and early diagnosis content in training curricula for pre-service at our medical training institutions, our universities, and so on. And the fourth one is to provide resources, incentives, and technical assistance through mentorship so that we expand the workforce and systems capacity to provide or link clients to services that are culturally competent and accessible. Now on the third strategy for this objective, we are looking at referral systems and improving linkages to care so that we reduce loss to follow-up. And here, the first activity is on identifying and addressing health system factors that impact timeliness of diagnosis of symptomatic cancer and to provide rapid linkages for confirmatory diagnosis. So here we really what we want to do is to reduce turnaround times for our patient from the time when you get into contact with the health system, you get a cancer diagnosis, still that period needs to be shortened. And then we have several sub-activities under that will unpack that. Then the second one is on a national cancer screening data repository for longitudinal client tracking. This will support follow-up and provide feedback to referring facilities, and also client navigation is included in that. The third one is integrating cancer screening into the ECHIS. This is the system that is being used to support PHPs, as they are now called, community health promoters, an electronic community health information system. The fourth one is on strengthening integrated sample and specimen referral and tracking systems so that we ensure timely relay of results. And lastly, we are looking at training, we are looking at mentoring and deploying community and in-facility navigators to facilitate referral and linkages to care. Our second last strategy, strategic objective rather, is on early detection of childhood cancers. And here now the first activity is on public awareness so that people can know that childhood cancers exist, that they are they may not be preventable, but they can be detected early, and that is very important. So we're going to do this by integrating the key messages on childhood cancers into our existing health promotion programs. We're going to also do this by training and engaging healthcare workers, cancer survivors, administrators, and I think my network may have become unstable again, but I hope you can hear me. So we are looking here at reaching, mobilizing parents and guardians so that children with symptoms can be taken to health facilities without delay. First strategy is on building capacity of healthcare workers for early detection of childhood cancers. So here we're looking at training of healthcare workers on the clinical presentation of childhood cancers and the importance of prompt referral. We are looking at promoting the use of childhood cancer assessment tool for evaluation of children for possible cancer within IMCI, the Integrated Management of Childhood Illnesses, an approach that has been very successful in our country. So we want to see how do we integrate that so that children can quickly be evaluated at primary level and diagnosed quickly for cancer. Then lastly, we are looking at establishing targeted screening and preventive surveillance services for children with retinoblastoma, and also other hereditary cancer predispositions syndromes. Our final strategic objective on multi-sectoral response and coordination has only one strategy, and this is really to strengthen our national technical working group on prevention and early detection. We are going to do this by reviewing the membership of the TWG and seeing the existing terms of reference, the membership and the TORs, so that we do this annually to ensure appropriate multi-sectoral representation. Cancer cannot be fought, and cancer prevention cannot be achieved only by the health sector. As you have seen, the environmental factors, we are looking at workplaces, we are looking at schools. So there are many people that we need, many organizations, many institutions that we need to partner with. The second one is on establishing and strengthening thematic committees of the TWG through regular meeting. We are looking at thematic committees for breast cancer, for cervical cancer, for risk reduction, and for screening commodities supply chain. Then the third one is participating in various risk factor specific technical working groups that are hosted by other ministries or other divisions, other programs, etc., so that we can feed back to our main TWG so that there is better coordination. So our participation as the players in the cancer space, even in TWGs outside the cancer space, is very important so that can enhance synergy. The fourth one and the last one is on knowledge exchange and sharing among relevant members and organizations working in this space through different consultative forum or knowledge exchange forums. This include things like symposia, conferences, and so on. So that's what we are looking at. As I said, that was the final one. And I just put this picture to just emphasize that screening can be done even at community level, can be done through screening camps and so forth. And if we get it right in prevention, everything else will fall in place. So with that, allow me to end there, and I am very grateful for your attention, and I hope that you have learned something that you will implement in your facility, in your county, etc. Over to you back, Dr. Mwenda. Thank you.
Thank you very much, Dr. Bosch. Thank you for taking us through Pillar 1, what we as a country, as our stakeholders in the cancer control space, are spelled out for ourselves in the next 5 years. So before we go to our next speaker, just quickly to put everything in context again, I hope we've noticed how the strategic plan is structured, moving from the goal, the main goal of every strategic area, or the working goal as it's called, then to the objectives, then to the strategies, then to the activities, and finally to the sub-activities that you're not seeing now. We are stopping at the level of the activities because of time. So I hope that sticks, because basically all the pillars are structured in that pattern. And maybe quickly, you've also noted, especially those people who are familiar with our previous strategy, that strategic planning is a continuous activity. So we build on what has been done and what has been achieved so that you can be able to address any gaps that were there in the previous strategic planning period. So with that, I want to invite our second speaker this afternoon, Dr. Morage, who is going to take us through Pillar 2. And again, to remind you, Pillar 2 is on imaging, pathology, and laboratory medicine. So Dr. Morage, if you are with us and if you're ready, share your screen and take it up.
Thank you, Dr. Manda. I'll be sharing my screen. I hope I'm audible enough.
Yes, you are.
Okay. My name is Dr. David Morage. I'm a Pillar 2 lead at the National Cancer Conference. I'll be taking you through the Pillar 2, which is has to do with cancer imaging, pathology, and laboratory medicine. This pillar has been slightly left behind, and in the previous strategy, it was referred to as cancer diagnosis. But this time we decided to focus more on imaging, pathology, and laboratory medicine, since it's more precise to this level, and they're the ones which are lagging behind in the whole cascade of patient journey. As less public facilities are offering these services, and they're mainly private, and therefore to enable to improve access, this is the pillar that deals with that. The overarching goal is to provide accurate, efficient, accessible, and timely cancer imaging, pathology, and laboratory medicine diagnostic services for better patient outcomes. This pillar has 3 strategic objectives, and objective 2.1, which is to strengthen cancer diagnostic imaging and interventional radiology services. This is mainly dealing with imaging. The second one is to strengthen cancer pathology diagnostic and laboratory medicine. And finally, to strengthen availability and capacity of human resource to support cancer diagnosis. And each of these pillars, each of them has 2 strategies under it. The first strategy, strategy and strategic objective 2.1 is to strengthen coordination for cancer imaging services. And its activities include strengthening the national imaging TWG, and which also will include reviewing the membership of the TWG, and also to review the terms of reference. The second one is to advocate for the development of the national QA and radiation safety and accreditation guidelines with in collaboration with the relevant professional bodies. This is really to look at the standards in which the radiology safety pertains radiology safety. The third one is to develop and disseminate standard operating guidelines in cancer imaging, including childhood cancer. Childhood cancer is, this is to ensure that children especially are not given a dose meant for adults, and to improve the standards for which even the machines that children are used in children. The third one is to develop and implement guidelines for utilization of gender technology. I think this advent of technology, there has been increasing use of teleradiology, but we have no standard guidelines. It's per institution or organization, which some may not have the guidelines. The other one is to advocate development guidelines and regulatory frameworks, procurement, evaluation, installation, commissioning of radiological equipment to support facilities, to support equipment that are purchased so that they are available, easily available to support purchase of in government from manufacturers as opposed to third parties who might increase the prices for the equipment.
Apologies for the interruption, Dr. Murage. We're getting a bit of interference, or rather some background noise from your end. I don't know, yeah, whether you can work on that, because we're getting some difficulties getting your presentation.
Okay, sorry. I have moved. I hope I'll be more audible now.
We can hear you clearly now. You can proceed.
The last activity is to develop and disseminate an imaging diagnosis directory for cancer. This is meant to avail a directory where you can easily know where services, cancer imaging services are offered and in which facility, and even the doctors that can provide those services. The second strategy was to increase access to quality, accurate, and efficient cancer diagnostic and imaging services countrywide. This is entails to upgrade and expand range of scope for medical imaging equipment and services available in the different levels of care, so that at least from all level 4s and 5s, if they have the imaging services, we are able to bring services closer and reachable to our clients. The other is to establish interventional radiology services in 2 additional national referral and regional cancer centers. Right now, interventional radiology services are limited, and this would enable it to be available at the level of regional referral. Expand nuclear medicine services at KNH, MTRH, and at least 3 regional cancer centers. We have about 10 regional cancer centers, and right now nuclear medicine is available at Kenyatta University, and this is now to expand to the other national referrals and also the regional cancer centers. The 4th one is to establish a national cloud-based radiology information system in cancer facilities, and also to link it with the local radiology information services and HMIS. This to enable data sharing, and data can be easily shared and also reported from facilities that don't have the expertise within themselves. The 5th one is to develop and disseminate standardized structure, staging, and reporting templates, and capacity building healthcare workers on their use to improve reporting standards. As we stand, the reporting is per institution and not standardized at all. And to some level, it does not meet the required standard. And this would help have standard reporting and uniform across organizations and facilities. And lastly, to promote the development and implementation of public-private partnership to address gaps in cancer diagnostic imaging and intervention radiology services. As I mentioned earlier, these services are majorly available at private. So, and some of them are quite expensive to set up and may not be available to all regions. Partnering with private institutions will enable have access faster. To our second strategic objective, to strengthen pathology, diagnostic, and laboratory medicine services. Some might seem similar to what we have in radiology because they suffer the same challenges. And in improving the coordination and standards of cancer pathology services, the first one was to strengthen the National Technical Working Group. And the second is to strengthen and equip the National Cancer Reference Lab to provide basic and advanced pathology and laboratory medicine services. The National Cancer Reference Lab is meant to provide quality assurance, especially for facility level laboratories, and it will provide the basic services so as to support facilities that do not have such services, and also advanced so that advanced that cannot be found anywhere else can also be found in the reference lab. The third is to develop and implement a national quality assurance and safety guidelines for various levels of cancer pathology diagnosis and laboratory services. This is to ensure the results from all labs are quality and can be trusted. The third one is to establish and implement quality control mechanism and EQA programs and ensure accreditation of all pathology labs. This is related to number 3, to ensure quality results are provided by labs. The fifth one is to review and disseminate national specimen handling guidelines and develop algorithm for pathology diagnostic workup of priority cancers. The cancer specimen handling guidelines are already developed, and our aim is to disseminate to standardize the handling of specimens in the country. And the sixth is to develop and implement guidelines for utilization of telepathology services and to develop protocol and guidelines for cancer diagnosis for priority cancers. This is similar to what I mentioned in the radiology side. The second strategy for this strategic objective is to increase timely access to quality and accurate cancer pathology and laboratory medicine services countrywide. And this entails to expand and improve availability of pathology laboratory infrastructure at a national and all county facilities. This is also to improve access at the level of county for each counties to have access to these services. Adopt and adapt innovative services, delivery models to enhance timely cancer diagnosis. This would include having rapid diagnostic centers so that the time for which it takes a patient to get a diagnosis is lower than what we have. The third one is to establish frozen section at the national referral hospitals, which are also limited, not available in all the national referral hospitals. Also to establish a national archiving system for tissue blocks, biobanking with linkage to gross specimens, whole slide imaging, and final pathology report. This is to enable to link all these together at a national level. Also work with the National Tissue and Transplant Authority to establish services for provision of blood and blood products to cancer centers. Which has also been, blood has been an issue for cancer patients, and this would also improve those services to be available to them. The sixth is to strengthen and expand availability of HPV testing platform for cervical cancer screening, including point of care testing. HPV testing has already been established at the national and counties, though had not been disseminated to all counties. This would enable the service to be available countrywide in counties. The seventh one is to expand the scope of the pathology services integrated into the existing digital laboratory information system and develop linkages and interoperability with other platforms. This is to improve the data systems that are being used from manual into a digital laboratory management systems. Also, number 8 is to form formal partnership between public and private diagnostic pathology laboratories, provide cancer diagnostic. This is also to improve access by partnering with private institutions at all levels. And finally, to establish integrated genomic testing services for improved cancer diagnosis, research, treatment, and monitoring of cancer patients. Also, genomic services has not been readily available. It's also available at limited, and this would also help us get to genetic testing for even screening services. Our last strategic objective is to strengthen the availability and capacity of human resource to support cancer care. And this, the first one is to enhance availability of human resource for cancer diagnosis. And the first one is to promote appropriate recruitment of personnel at cancer imaging, pathology, and laboratory medicine facility as per international and national standards by level of care. Right now, we are having quite low numbers of the required personnel at different levels, and to improve cancer diagnosis, all the cadres that are required per level of care and by international standards and national standards are required to be recruited and employed and also promoted as per standards. Secondly, is to advocate for the definition of scope of practice, certification, and accreditation of pathologists, laboratory medicine professional, radiologists, and other allied professionals, so that they are recognized as per their training and requirement. Finally, our last strategy is to enhance the capacity of human resource for cancer diagnosis, which includes to design, develop, and implement a common training plan of human resource needs in cancer diagnosis with a focus on sustainability, retention, continuous learning, and improvement. And second objective is develop and disseminate a training package for specimen handling, cytology, peripheral blood films and bone marrow aspirate, and histopathology to improve early diagnosis of cancers. Okay. The third is to collaborate with local and international institutions to establish and strengthen local fellowship programs for subspecialty training in cancer diagnosis. The fourth is work with health training institutions to include basic cancer diagnostic content in pre-service training curricula and medical and other health workforce and training programs. And also finally is to provide a directory of benefits and local referral resources for laboratory personnel. So all these are meant to improve the numbers for the human resource in terms of training, and also identify where to refer client. Thank you for listening. Back to you, Dr. Amanda.
So thank you very much, Dr. Morage, for taking us through Pillar 2. And I think colleagues, truly you can attest that Pillar 1 is a base of the pyramid, and Pillar 2 is the entry point to cancer care. So two critical pillars or strategic areas for cancer control in the country. So thank you for taking us through our two speakers. So we have some time to respond to questions and have as a bit of discussion. I want to request the participants, we are quite a number in this call. Utilize the Q&A. There's a tab on the bottom of your screen, written Q&A. So if you have any questions, post them there so that you can be able to, I can be able to read them out to our participants, to our panelists, to respond to them. So, and quickly, and again, for participants who may have joined after we started, this is a first in a 3-series package of webinars to disseminate the recently launched National Cancer Control Strategic Plan 2023 to 2027. So this strategy was launched on Friday last week, Friday the 14th, by the Principal Secretary in the Ministry of Health in the presence of other dignitaries and also majority of the County Executive Committee members for health for the 47 counties. So we are basically kickstarting the process of implementation that includes disseminating it as widely as possible. So looking at the Q&A section, I'm going to read out the questions that have been posted here, and I think I'll put them to the panelists. So the first question from Tony is, thanks for the update. Can you advise on the importance of abstaining from sex in HPV patients? I think that goes to Dr. Bor.
Okay, thank you, Dr. Mwenda. Tony, the question is a good one. Maybe I can just comment that HPV is a very common virus. I think studies have shown that about 86% of women will have HPV by age 50. So it's a very common virus. So of course, healthy sexual behavior is very important for people who have HPV and even those who don't. And condoms don't fully prevent HPV transmission because it is not only spread through penetrative sex. So yes, abstinence is one of the important strategies, but let us even focus more on primary prevention. We have the vaccine now, which is available for 10 to 14-year-old girls. It's safe. It's available for free in our public health facilities, and currently it is in 2 doses, but we are looking forward to it being now provided even through a single dose, which has been shown to be effective. So yeah, that's what I can say to that question. Thank you, and back to you, Dr. Mwenda.
Thank you, Dr. Bor. The next is rather a comment. Applauded the ministry for distribution of thermocoagulators. So these are equipment that are used to treat cervical precancerous lesions. So thank you, Hilary. And just to inform maybe the participants here, yes, the minister has really done a lot to make available some of these facilities. So as healthcare workers, let's create, the awareness. Let's continue screening and treating those who are bound to have these precancerous lesions for cervical cancer. There's a question from Charles. Charles is asking, KNH, I'm assuming that's Kenyatta National Hospital, takes too long even after identifying cancer for start of chemo or radiotherapy or radiography. It's actually radiotherapy. Anything can be done to reduce signatories in order for medication to start before cancer can advance to more worse. Have a patient there for 2 weeks. Now nothing has been done, waiting for oncology to sign. What can you do to reduce these long waits? I think these falls, basically this is talking about, waiting times, sometimes maybe the diagnostic process, staging process, planning or management may be taking long. I do know this falls in another pillar. So in pillar 3 of the strategic plans, so which we're going to have in our next webinar. But I don't know, maybe Dr. Morage, you can have a quick answer, short answer, maybe some of the drivers of delays in cancer care, not just KNH, but maybe across the country, which you're trying to address in the new strategy. Dr. Morage?
Sorry, I lost you for a moment. I didn't get the question.
Oh, okay. Sorry, I just decided to pose this question. This question is more fits more in pillar 3, but I wanted, as you know, in a way, responding to Charles, if you can state to us, you know, some of the bottlenecks or the challenges that we have in the cancer diagnostic and management process that causes delays and that cuts across and that we are trying to address in the new strategy.
Oh, thank you, Dr. Mwenda. Most of the challenges we faced in diagnostic is the delay in getting
Dr. Murage,
diagnosis, and
okay.
these kind of facilities that offer these services are you getting me?
Yes, you're back. We had lost you for a second, but you're back. Thank you.
Oh, sorry. I was mentioning that facilities that offer these services might be overloaded and therefore tend to have a long waiting time for getting results. Another major challenge is financial constraints that come with the diagnostic services. Most diagnostic services are not covered NHIF, and therefore people have to have out-of-pocket costs, which also cause a delay because if you are given a bill that you cannot handle, you go look for money and then come back later when the disease might be already advanced. And thirdly, the other challenge we are trying to address is very few people know where to get and seek those services because very few facilities offer them, and we don't have a clear referral guidelines for these services. This is the other challenge we are trying to address in this strategy. That's all I can say about you, Dr.
So thank you, Dr. Morage, and I think that's also, you know, touches on the point that David is bringing across, again, the issue of diagnostics, and to, you know, again, emphasis on that area. So this strategy, if you look at it, it's trying to specifically fill gaps that were noticed in the last 5 years, and you know, the cancer diagnosis is one of them, and that's why they have, you know, quite a number of strategies to improve access. And by access, I mean both physical access and also financial access to cancer diagnostic services. There's another question here from Caroline. How do I get to be trained and equipped as a social worker in order for me to participate in helping with cancer? Dr. Bor, I think you can respond to that.
Thank you, Carol. That's a very noble question and a very noble interest to be trained in cancer care. As a medical social worker, I believe you have a big role, especially in treatment, supportive care, palliative care. Of course, you also deal with many clients that can also help in prevention. Although I see maybe as a medical social worker more a bigger role in treatment, supportive care, palliative care. So I may not have an answer for you currently, but you could go to our e-learning platform. That is, you could go to MOH Virtual Academy and look through the cancer courses there and see which one you can take up out of interest. But I'll take that up as a challenge and will liaise with my colleague who handles the treatment pillar and try and see what training can be available for even for social workers in cancer care, in the continuum. I think another area is in patient navigation. So that's a challenge to us as a program on how we can involve you more. Yeah, thank you.
Thank you. There's also another question and comment from Dennis. Dennis is saying, thank you for the presentations. It's wonderful that you take time to disseminate such policy documents. Just wondering, how have we been able to evaluate whether the previous 2 cancer control strategies met their stated objectives? So Dennis, maybe I can take that. So, so for the first strategic plan, the one that covered the period 2016 to 2017, we actually did an evaluation exercise, what we call impact assessment. So impact assessment is actually a UN tripartite support mechanism for countries to evaluate their cancer control, interventions. So we're able to do an impact assessment in 2016. So that informed the drafting of the previous strategy now, the 2017 to 2022 one. And then last year, we conducted, 2 evaluations. We conducted an internal evaluation. Basically, we're tracking the implementation every year, but now we did an end-term evaluation. So that was like an internal evaluation. And then we also requested the tripartite mechanism again from the UN agencies, the WHO, the International Atomic Energy Agency, and the International Agency for Research on Cancer, IAC. We requested for another impact assessment. So again, for the strategic plan 2017 to 2022, I can say we had both an internal evaluation and an external evaluation. That's why we are very confident that the areas we focus on in this current strategic plan are actually the areas where we have gaps. And if we invest there as a country, if we put our efforts there, we are going to improve the cancer control space. So there's a question by Charles again. Is there any way KNH can do to reduce waiting times before medication start? And again, I think we've discussed that. There are many aspects to why we have long waiting times, and I don't think it's just KNH. And I do feel that with some of the interventions that are stated out in the current strategy plan, we should be able to address this issue once and for all across the entire country. So again, Bretta, appreciating this, and then whether we're going to share the presentation. Yes, we'll do, and we're going to do also a physical dissemination in the counties and share the materials, and the strategy will be available shortly, as Dr. Bor mentioned, in the MOH website for download for all of us. Then there is an anonymous, okay, I can't see the name, or anonymous. Okay, so the question is, why can't we have access to these services locally as we did with malaria campaign? I don't know. Quickly, Dr. Bor, maybe, and even Dr. Morage, you can dive in. Can we benchmark with malaria control?
Of course, we learn from our older programs that are more established. And I agree that the information about cancer needs to be as widespread, and even the program needs to be as established. The only challenge, or the only thing that we may not match malaria, is the funding. That is a challenge for us. However, we do borrow ideas and learn from them, even in communication, and in monitoring and evaluation of our programs and so forth. Dr. Murage, do you want to add maybe?
Yes, we learn from programs that are well established, considering cancer has been a little bit, it's relatively new compared to other programs. And we also realized that cancer is also specialized, and different levels of care have different specialties. And I believe each level of care has their role in terms of cancer diagnosis. And therefore, as you go up the ladder, you get more specialization with each level you go to. Therefore, cancer cannot fully borrow from malaria, but whatever level has, we are trying to decentralize every level of care, the management to every level of care, to allow for early diagnosis. Thank you. Back to you, Dr. Amanda.
So thank you. And another question here that I think also comes to you, Dr. Morage. Why is it, from Victor, why is it that some cancers take too long to be identified?
Okay, there are a number of reasons I can mention why cancers take time to be identified, including that different cancers have different modalities and for identification, and this might affect them. And also, depending on which gender it affects, also plays a part in their identification. For instance, cervical cancer is very cheap to diagnose as compared to breast cancer. And therefore, I think, and it also, breast cancer, you might have to pay from 2,000 and above for it to have screening using the modalities recommended. Whereas using VIA, you can use as low as even I can say 100 or 200 shillings for you to get screened. And I think this is one of the ways that can affect the diagnosis for different types of cancers.
So thank you. Yeah, thank you, Dr. Morage. I think we've addressed the issue about the turnaround times. I think it's a major issue, a major concern is coming from a number of participants. Faith is asking whether how can a pharmaceutical technologies upgrade like we have oncology nurses? There are so many of us outside here up for the task. Again, that maybe is more in pillar 3. Dr. Bora, I don't know if you have any quick comment there, but I know it fits more in pillar 3 that we're going to discuss in the coming webinar.
Yes, I can add, Dr. Mwenda, that those oncology nurses are also trained in screening and they have a role. And we are even training some on colposcopy and LEAP because their scheme of service allows them to do that. That is for treatment of advanced cervical precancer lesions. So yes, and then now pillar 3 will add. We'll have more to unpack about oncology nurses. Thank you.
All right. So are there any guidelines on the screening or management of chronic or recurrent H. pylori infections? I think so. This was mentioned as one of the oncogenic, pathogens. So, Dr. Bor?
Currently, we don't have any guidelines, local guidelines. But when we review our screening guidelines this year, let's see what the expert panel that we put together will advise, and what the evidence, the direction in which the evidence will lead us. Thank you.
Right. So another question coming to you. Once someone has the vaccine, is it important to do HPV DNA afterwards? So HPV testing. Also, what are the guidelines for both men and women who want the vaccine?
Thank you. And I have seen a number of questions still on HPV vaccination. So once somebody has the HPV vaccine, is it important to do HPV DNA afterwards? I don't see the direct relation. But what I can say is that our screening guidelines recommend that even for those who have received the vaccine, they still need to do regular screening. Reason being that there hasn't been enough evidence to show that once you have received the HPV vaccine, screening is no longer beneficial. So that's what I can say about that. I hope that in a way answers your question. The guidelines for both men and women, I think in our country, we are really focusing on the girls, the issue being a vaccine supply issue. And there's also another question that was asking further down, can HPV vaccine work for 40-year-olds? And another one that was asking, does vaccination with HPV vaccine benefit women who are already sexually active? And another one was asking, is there a plan for HPV vaccine to be offered to boys? So I want to lump those together and say that currently vaccine supplies do not let us vaccinate both boys and girls. It's just the way, remember when we had the COVID vaccination, initially we could only focus on the high risk, the people that were considered to be high risk. For obvious reasons, that is where the highest impact would be. And so the same thing with the HPV vaccine, global supplies are not yet allowing us to vaccinate both boys and girls, although there is benefit. So we focus on girls because cervical cancer is a major killer. Whereas still HPV causes other cancers, even in men, anal cancers, penile cancers. But in terms of the burden, cervical cancer kills 9 women every day. So that is why the investment is more there, because the highest impact will be seen there. Now, for if anyone wants to get the vaccine and they are not within that target age 10 to 14 years, I don't think the stocks at the facilities will allow for them, and the policy right now will not allow for them to receive the vaccine at the public health facilities. However, the vaccine is offered at private facilities, some private facilities, and it is quite costly. I may not remember exactly how much, but it is not less than 6,000 the last time I checked. And will it work for a woman who is sexually active in the age group that I saw somebody has asked? First, they would need to do an HPV DNA test to rule out whether they already have HPV, because vaccines work best if you're not exposed to the, to the pathogen that it's fighting. So yeah, that's what I can answer all those questions about HPV vaccine together. Thank you.
Thank you, Dr. Bor, for taking that batch of questions together to save us on time. There's a question on can GERD, that's gastroesophageal reflux disease, cause cancer? Maybe a quick one there is no, but Barrett's of esophagus is a precancerous lesion for cancer of the esophagus. Richard is asking, how do you monitor turnaround time for diagnostic specimen? Any guidelines for handling biohazard materials for cancer materials? Dr. Morage?
At the moment, there is no monitoring of TAT at facility level. However, the National Cancer Reference Lab, TAT is being monitored. And to address this issue, the establishment of linkage with LMIS would help be able to monitor the TATs at all facilities. Also, for the second question, how do we, is there guidelines? I don't think there's a guideline specific for cancer for biohazard material that is currently available.
Okay. Thank you, Dr. Morage. There's a question on how do we relate the role of smoking in relation to the top 5 cancers to a layman? Because the community people relate smoking to lung cancer. Dr. Bor, maybe you can take that quickly.
Dr. Amanda, do you want to take that one? Let me just say that smoking, tobacco, and yes, tobacco has been linked with lung cancer, but it is not only lung cancer. It has also been linked with other cancers, including laryngeal cancer, oral cancers, esophageal, throat, bladder, even kidney cancers, liver cancer, stomach, pancreas, colon cancers, colorectal, and even cervical cancer, by the way, and even some leukemias. So, and it's not just smoking, but even snuffing or chewing tobacco has been shown to be linked with cancer. I may not be able to explain the exact mechanisms. Maybe Dr. Amanda, if you have any idea, but I know that it causes damage to the DNA. And that damage in the DNA is propagated when the cells multiply, and then it triggers the abnormal multiplication. Yeah. I don't know if that will relate to a layman.
Yes, I think it's I mean, the mechanism of how tobacco causes cancer really, it's much more than the smoke itself. So, there are other complex pathways, and that's the reason why other forms of tobacco also cause cancer. And that's the reason why tobacco use causes other types of cancer, other lung cancer or airway cancer as well. So there's a comment about molecular profile of tumors being an essential component, and they confirm that. And that's why you saw that there's actually specific activity mentioned in one of the strategies in Pillar 2 to ensure that we make those services available in the country. Let me just go down and see if we've answered on the HPV vaccine. Okay, let me see. Mine is not a question, it's a concern. I believe this session is not reaching that large coverage. Is it possible such updates to be sent to healthcare workers, to even those in rural areas, because clients from those areas have their ailments taking too long to be diagnosed? And yes, I confirm, as I mentioned, there will be a number of approaches to disseminating the strategy across the entire country. So this is just part of it. It's just part of the, the wider scheme of disseminating. Where can I get the vaccine and for how much? I'm assuming this is HPV vaccine, Dr. Board. Did you mention about where people can get the vaccine?
So, the public health facilities, it will be available for 10 to 14 hours. Maybe you can try some private facilities. I may not have any specific ones that I can advise you on. Yeah.
All right. Do we have some small strategies put in place to avoid any chance of cancer misdiagnosis? So any strategies to avoid cancer misdiagnosis, Dr. Morage?
Yes, this is by ensuring all facilities, especially in laboratory and testing, are enrolled in a quality assurance program to ensure that the results they are giving are up to standard.
All right. So is PET scan okay for screening purposes, especially for those difficult cancers who usually are confirmed of late stage? That also comes to you, Dr. Morage.
I believe PET scan is not a screening modality, but can be used as a diagnostic modality.
Okay. There's this comment here, which I think we mentioned that is going to be addressed in the next series. The issue about pharmaceutical technologists upgrading to, I'm assuming, to become a pharmacist and then maybe to become an oncology pharmacist. So I think that's what we'll discuss in PLR3, where we handle issues of cancer treatment, palliative care, and survivorship. Let me see. How do we get the strategic plan? I think we mentioned that it will be on the MOH website soon, and also the physical copies will be disseminated to the counties. Okay, we also need for information about Hodgkin's lymphoma, which is eating our people unknowingly. Yes, that's agreed. Hodgkin's lymphoma is one of the focus cancers for childhood cancers for the Global Initiative for Childhood Cancer Control. And so I think I agree with the participants. Okay, let me see if there's another question that we've left out here. There's a question about agrochemicals. Some agrochemicals and pesticides have been linked to risk of cancer and are banned in some countries. How comes they are liberally sold over the counter in our setting? Dr. Bor, maybe you can mention some of the strategies stated out to address that issue.
Okay, thank you for the question, and a very good question. And this is why I did mention that this is one area in addressing environmental and occupational risk factors. It's an area where we have not been able to do so much. You know, the cancer program is a relatively young program. We're about 5 years old. So, of course, we prioritize the lowest hanging fruit, the lowest lying fruits, which include establishing screening programs. But in this strategy, we have actually outlined activities to address this environmental determinants, and it is looking at agrochemicals, pesticides. We are working with the relevant stakeholders now, and we are going to join together with them and collaborate so that we can see how to reduce exposure for our Kenyan population, to make sure that food is safe. One, for example, that I can mention is glyphosate. And I can tell you that the ministry is in discussions with relevant stakeholders on how we can reduce, or actually how we can stop or ban glyphosate. So there are discussions going on that one currently, and I think that will set the stage for even other discussions on other and actions on other chemicals. One of the things mentioned in this strategy that I think I highlight is promoting research on the role of these chemicals in cancer causation. Another one where our weakness may be is on enactment and enforcement of policies, laws, and regulations and guidelines. Of course, public awareness is also another thing, because if the public are fully aware, then we know that they also can advocate for banning of some of these substances. So look out in this strategy. When we're implementing this strategy, that is one thing that will really be addressed. Thank you.
Thank you, Dr. Bor. And as we close, because we are I've run out of time that was allocated to us, there's a question by Jane. As a clinician, any available course on cancer? The answer is yes. Jane, we have courses on e-learning materials on what we call the Ministry of Health Virtual Academy. So just type that, and you should be able to access those materials. We also have an application called Saratani, which again you can be able to register and access the same materials conveniently. And this is, a broad array of materials on cancer early diagnosis for primary healthcare workers. So colleagues, allow me to end there. So I want to remind you again of our upcoming a series of webinars targeting pillar 3 and pillar 3 and pillar 4. Some of the questions that were asked in this forum will be addressed in those and during those forums, and then the last series that will tackle pillar 5 and the meal framework. Some may be on this platform, some may be on other platforms that we're going to share the information widely. I've also seen that in the income industry, there's also a discussion on this platform that I think we just saw the poster shown on the to us that will be focusing on something that is relevant to cancer control, hepatitis B, I think, and C elimination goals. So this is also, I think, in a major way, a cancer control agenda, on this platform. No, this is in the morning, in the evening, late in the evening. Yeah, so look out for that as well. I think it supports, some of the interventions mentioned in this strategic plan. So again, thank you very much. And again, I want to thank our panelists this afternoon, Dr. Bor Malenya and Dr. David Murage. Thank you for taking time to be with us, and for all the participants who have been able to join us this afternoon. Thank you very much. Look out for this strategy. Check out your roles in the various capacities and institutions that you work for, so that all of us can move towards reducing the preventable burden of cancer in Kenya. Thank you and have a great afternoon.